Hello, welcome to the Massachusetts General Hospital Frontal Temporal Disorders Unit Community Forum Friday webinar series. My name is Katie Brandt. I'm the Director of Caregiver Support Services and Public Relations for the MGH FTD unit, and I'll be your host for today's session. Today's session is Understanding Hospice Care and Processing Grief with Dr. Bernice Burkharth and Susan Toleos. This is a really important topic for our community of persons living with a diagnosis of dementia and their caregivers. At this time, I'd like to welcome our caregiver support specialist, Amy Marchesano, to the session. Amy?
Thank you, Katie. I'm so excited to be here today speaking with Dr. Burkarth and Susan Toleos. It's going to be a great session.
I know, and you could see that the two of us have smiles on our faces, and I think that that's one of the things that we hope to bring forth in the session today. This is a heavy topic, talking about hospice care and grief, but I was thinking that maybe we could talk a little bit about why. Why did we think that this was important to bring this to our community?
Right, Katie, we have so many questions that often come from our support group members, as well as caregivers and their loved ones living with a diagnosis. And so this would be a great opportunity to talk about why it's so important to have the right supports.
Yeah, I always say, we accept it that all care doesn't happen in the clinic, and that families need to get connected with the amazing community organizations available to them at every stage of their journey of care with Alzheimer's disease, frontal temporal dementia, and related disorders. So I hope that this will be an informative program for everyone today, and that maybe even will help to encourage folks to reach out and learn more about a local hospice program in their area. So to kick off the session today, I would love to introduce our first speaker, Dr. Bernice Burkharth. Dr. Burkarth has been in the practice of hospice and palliative care since 2005, and she is currently the Chief Medical Officer of Merrimack Valley Hospice. A physician leader, she works with the medical services team to provide access to medical care in times of serious illness and at end of life. Dr. Burkarth works at bolstering a strong team to serve the needs of palliative care and hospice patients through fostering a collaborative, professional environment where shared learning and establishing best practices are encouraged. She earned her medical degree at Temple University School of Medicine in Pennsylvania and completed her residency in neurosurgery at Albany Medical Center in New York. Amy, I'm going to turn the program over to you for a wonderful conversation with Dr. Burkharth.
Hi, Dr. Burkarth. Welcome to the session today.
Thank you so much, Amy. And Katie, thank you both for having me on here to share some information about hospice and palliative care. And thank you also for having Home Health Foundation in Merrimack Valley here to share that information.
It's our pleasure. I thought I'd just start out the session today, Dr. Burkarth, by asking you, what is your role at the Merrimack Valley Hospice? And could you tell us a little bit more about the organization itself?
Sure, yeah. So Merrimack Valley Hospice is an agency of Home Health Foundation, which is part of a larger organization called WellForce. And interestingly, Home Health Foundation has actually been around in one form or another since the late 1800s, when the area's first district nursing program through Lawrence General Hospital, in collaboration with them, provided nursing care to working families, mill families in the Lawrence, Methuen, and North Andover area. And we extend throughout the Merrimack Valley and a little beyond. So in Malden, for instance, we have a branch there as well as in Lowell. And those areas also started working in the home care arena in the late 1800s and early 1900s. Today, we have the full continuum of care, I like to say. And it's interesting that Katie was talking about at any stage, right, of an illness. So at Home Health Foundation, we have, of course, our Merrimack Valley Hospice, and we also serve New Hampshire and Southern Maine through York Hospital Hospice. And we have our home health agency portion, as well as private duty care through Commonwealth Nursing Services, our palliative care program, and of course, the hospice program that I referenced first. Thank you. And my role there, which is as the Chief Medical Officer, is to provide medical oversight for the care of our patients in hospice and palliative care, and to assist in any way that I can in helping to provide the care through the home health and our private duty care as well.
That's wonderful. And thank you for your service. Very important for our caregivers. And that's what I wanted to ask next. Many of our caregivers are family members of their loved one has been diagnosed with dementia. And this may be their first experience with a hospice program or any of the services that you provide. Can you define hospice specifically and tell us a little bit more about what that exactly is?
Absolutely, yes. Hospice is a philosophy of care, right? And a lot of people think of hospice as a place to go, but I want to really emphasize that hospice care, which I will explain a little bit further in, is able to be provided in any place that a patient, that a person, right? Because we are talking about people and their families, that individual lives. And that could be in their residential home setting, in a nursing home setting, in an assisted living facility setting, as well as even in our inpatient unit, the High Point House. So this philosophy of care is one, this concept is for patients and people whose illness is no longer responding to treatment, to curative treatment, and it is designed to improve the quality of life by offering comfort, personalized service, and a caring community, right? Through the team provision of hospice. And I think we'll get to that in a little bit about what services are offered. But it is one of the important concepts of it is that it's provided by this interdisciplinary team that supports the patient and family, because that's our unit of care, right? It's not just the patient. As you know, the caregivers and the family are often involved in, well, they're very involved in the life and support of that ill individual. So that support is extended to the patient's families throughout the illness and even for at least 1 year beyond the illness. I think you'll be reviewing with my colleague a little bit later as well. And again, the important part is that this kind of care, this care that's focused on comfort and dignity, is one that focuses on caring, right? Not curing, on relieving the symptoms associated with serious illness and with terminal illness. And we will, I think, dive a little bit deeper later on in the differences of the types of care that one can receive when they're seriously ill and when that state of illness transitions to a more terminal phase of illness, which is what most people are used to hearing, right, with hospice care. It is also a benefit that is provided to people who, through most insurance companies and importantly through Medicare.
Thank you. Thank you so much for that comprehensive overview of hospice and the types of support and care that is provided, that the focus is on keeping someone comfortable and their care with the family as well. I just had a question for you, Dr. Burkarth. You did touch a little bit upon this in your comprehensive explanation of hospice. Oftentimes, we hear the words hospice and palliative care together. And so I think some of us, I would like to know, what is the difference and do they work together? Maybe you could explain the terminology a little bit for us.
Absolutely, yes. It's a question I get often, and palliative care and hospice care are on a continuum, right? And so palliative care typically is engaged earlier on in the process. Folks like to refer to palliative care as being appropriate really at any stage of illness and at any age. And one of the main differences, that's one of the main differences between palliative care and hospice. Hospice, as we're more familiar with, is more specialized to the very end of life. And when I say that, I mean, as defined by the Medicare benefit, which is one that suggests that hospice care is most appropriate when a patient's prognosis is limited to 6 months or less. And so typically a patient will, in the ideal situation, transition from palliative care intervention, which is also geared towards comfort, right, and symptom management and the relief of those symptoms, to then more specialized end-of-life care when that illness transitions over to the more terminal phase of illness. And one of the other main differences, I would say, between hospice and palliative care is in how it's provided. So palliative care, when it's provided, goes through whatever insurance that individual may have. Hospice care includes the provision of medications, any kind of medical equipment, and of course the care through the different specialties and disciplines that we'll talk about that are all covered through that hospice benefit. And again, that difference with palliative care is that each individual piece goes through the insurance for that individual. Again, they both focus on relief of symptoms, right? With comfort being the primary aim and goal, comfort and dignity, of course. And again, they transition along that continuum.
Thank you, Dr. Burkarth. That definitely explains the difference between those terms of palliative care and hospice. And you did give an explanation that kind of leads me to my next question, actually, which I was thinking about the different services within hospice. I know you did touch upon a few different things, such as, medication, and some of us may be thinking, well, it involves nursing care or it involves counseling. Could you give some examples of the specific services that are provided if someone requests to work with hospice?
Absolutely. And I brought a little visual to go along with this, as I like to be able to look at things in different ways. So you can see here, our center, as I mentioned earlier, our unit of care, if you will, right? Our focus is the patient and the family. They're at the center of everything. And they help to define what their goals are, and then we support those through the hospice program, which includes this fantastic concept of the interdisciplinary team. This interdisciplinary team, importantly, includes the individual's own physician and care team. And I think that's something that people get really anxious about when they think about moving on to hospice care, aside from all the other things they can be anxious about with this, is that they may have to give up their longstanding relationship with the physician and the care team that has been caring for them all along. And the truth of the matter is that is a patient and family's choice as to who they're attending, if you will, is under hospice care. So they can maintain, and we encourage them to maintain that relationship. In addition to their own physician serving in that role as attending, there's a physician, a hospice physician, who is also on the team that can serve as consultant to that patient's primary physician and to the hospice team in general. Additionally, there is, of course, the hospice nurse case manager. This individual is almost a hub, if you will, of the support for that individual and their family. They coordinate and coordinate the care, make sure that the plan of care that has been developed collaboratively with the individual and their family, that this is followed. We also have the support of hospice aides who provide assistance with personal care, such as dressing, bathing, and can also provide light meal preparation. Social work services available to assist the entire family with day-to-day concerns that often come up when a patient is facing a life-limiting illness. We provide emotional and spiritual services through our chaplaincy, who offer multi and non-denominational support to patients and families, and often act as a liaison to the patient's own religious community. We offer bereavement support, which includes counseling and support services totally focused on the needs of the patient, family, and loved ones. This support is available for an extended period, a year following the loss of the individual. And those services can begin before the patient's losing the patient, in the form of anticipatory grief support as well. And I believe you're going to be speaking with Susan Toleos, so I will let her go through a little bit more specifically the services through bereavement support. There are many virtually as well as live and community-based support groups. I will let her go on through that as well. We also have expressive therapy services, including our music therapists, who find a great adjunct to the care of our patients, and volunteer services. So we can pair up an individual with volunteer services, as well as honoring our veterans. We participate in a program called We Honor Veterans, where we acknowledge and honor the service that individuals have provided through our armed services.
Wow, that is really amazing. And when I think about our community, and when I think about people living with a diagnosis of dementia and their caregivers, I think of exactly of those types of services, and being person-centered, as you discussed, is so important. That multidisciplinary approach and having all the key components for wrapping around that person during this time. You know, if our families watching today are interested in becoming, more familiar with hospice, learning about it, or finding out if they're actually eligible for those services, there's such a comprehensive array of services. How would they go about initiating that process?
I like to think that the first step begins with a conversation with the primary care team for that individual and for their families. They know them best, right? To kind of take a pulse, if you will, of where the individual is along the trajectory. In terms of, and I'm going to speak about both, if you don't mind, palliative and hospice care, mostly because, again, they're on that continuum, and they serve as different entry points to access the different services. So, and the reason I bring the palliative care up is because, as I mentioned earlier, palliative care is that extra layer of support that's provided to patients, families, and their care teams, right, at any stage of illness. That is a phone call. And you can call in with questions or inquiry to our hospice. The number is provided here, and really any hospice, but for our hospice, here's the number. And you can begin by asking questions of the referral team. They're all very skilled and knowledgeable in terms of understanding where someone is along the trajectory of their illness. For hospice care, because it is a benefit through a prescribed program, right? Then there are eligibility requirements for hospice care as it pertains to dementia and the neurologic disorders that we described. And it's essentially when the chronic illness and the serious life-limiting illness transitions into a terminal phase of illness, typically characterized by a loss of ability to ambulate, or walk independently, recurrent infections, persistent weight loss. Again, signs that point to us to a more limited prognosis towards the end of life. And that can be determined again through referral and nursing assessment to see where that patient is, and communication with the primary care team as well.
Well, thank you very much for that explanation, because I think it sounds quite simple to make a phone call, and also talking with your own, PCP, of course, is something that could be arranged easily. So that's less overwhelming for a caregiver to know that they could simply pick up the phone and ask a few specific questions to start the process. And so as we end our interview today, I just wanted to ask you, do you have a final takeaway message that you would like to leave with our community today? Anything on your mind that you think you would like to share that we should know?
I get asked this sometimes, after a conversation like this, and I think to myself, very often in life, we don't get a lot of choices about some big things, right? Certainly about when we die. But we do have choices about how we live until then, right? And the National Hospice and Palliative Care Organization had a tagline at one point that said, "It's about how you live." And it truly is. I think, to my mind, that is probably one of the most important messages to take. And I have to say, again, thank you to you and Katie for sharing this information and helping to dispel perhaps some of the myths, right, about this kind of very important care, and giving people the opportunity to choose how they live.
I think that's a wonderful takeaway message, and your compassion is so evident. And I really want to thank you for our interview today. And I hope that this will help some families watching today to learn more and have those questions answered that they may have been thinking about. So thank you so much for your time today.
Thank you.
I'm going to turn it back over to Katie Brandt.
Wow. Thank you, Amy and Dr. Burkharth. I think that right away, we've dispelled some myths about hospice and palliative care. And I hope that this provides some concrete information, thinking about how hospice can be provided wherever you are, whether it's at home, in the skilled nursing facility where your loved one is living, or even at a hospice house. We heard that hospice is covered by Medicare. So that means for most families, hospice is not going to have an additional cost or expense. One of the things that really resonated with me was this idea of the interdisciplinary approach to care. Because, in the MGH FTD unit, we take that to heart. We know that not only does care not happen in just one place, but often it takes more than one type of professional to meet all of the needs that families have as they travel the journey of caring for a loved one with dementia. I really loved the person-centered approach, the family-centered approach to care. I heard about the values and goals that families may have, and how that approach can be central to your family's care planning. Thank you so much, Dr. Burkharth, and we look forward now to hearing from another member of your team, Susan Toleos. Susan is a licensed mental health counselor who has worked in the field of hospice care for over 20 years. Susan utilizes her master's degree in spirituality and counseling psychology from Lesley University through her role as counseling services manager for spiritual and bereavement care. She leads the agency's chaplaincy, music therapy, and grief counseling staff. Susan is moved by the power of grief and vulnerability. Among Susan's favorite things to do on the job are teaching her fellow colleagues about grief and facilitating things to do in support groups, and in the community. Off the job, Susan enjoys listening to music, playing tennis, and endless conversations with her 3 children, ages 20, 17, and 12. I now welcome Susan and Amy back to our program for a continued discussion about hospice and grief supports.
Thank you, Katie. Hi, Susan. Thank you for joining us today.
Hi, it's my pleasure to be here. Thank you.
I'm really looking forward to our conversation. I thought I'd just start out by asking you if you could explain your role at Merrimack Valley Hospice and a little bit about what that looks like and how you work with families.
Right. So I'm the counseling services manager for bereavement and spiritual care, as Katie said. So what that means is all of our staff members, all of those interdisciplinary team members who are dealing with anything in the realm of counseling, I lead and oversee and work with. And that includes our music therapist. That includes our chaplains who are providing spiritual counseling, and that includes our grief counselors, all of which represent how comprehensive hospice care is, that it's more than straight medical care.
That's wonderful. There's definitely a wide array of services that you're involved in providing. And what I was curious is if could you just tell us a little bit more about specifically about the family experience? And for example, what can families expect to experience when they're connected with a hospice program?
Right. Yeah, I think that's another really unique facet of hospice care, which makes it so great, is that it's a whole team of people, and a whole team of people that's kind of treating a whole team of people, right? So we consider our clients to be the patient and anybody that the patient deems their family, which could be, actual family members, loved ones, anybody sort of on the patient's team. So all the services that we provide are there for those people too, for family and loved ones of the patient. We consider it to be that all of us are working together to get the best kind of care for this person at this special time in their life. Yeah.
I think that's such an important designation, that it's not just the family, true, biological family members,
Mm-hmm.
or it could include loved ones, friends, neighbors, anyone, as you said, that's involved with the care, or anyone who's close to or considered family of the patient. I think that's a really important point. And I was just curious, how would they interact with the care team? Could you give a couple examples or tell us a little bit about, the services that they would be interacting with?
Sure, absolutely. So, for instance, a chaplain may, the first contact they make may be a family member or loved one of the patient. A chaplain is interested in providing spiritual care for everybody, everybody on the patient's team. So they may have appointments and sessions that may solely be with the family member or loved one. They may do it jointly with the patient. They may be doing both. They may be meeting with the patient, and they may be also meeting separately with the family member or loved one. So yeah, the family members and loved ones can expect for our team members, particularly the ones that I lead, to be reaching out directly to them, to ask if, to provide care, and ask if they are interested in the services that they provide. One more thing is that, if this patient does die on our services, in order to even call ourselves a hospice, we must provide care. And so in this case, it would be solely to the family members and loved ones for 13 months after the patient dies. And that's in the form of grief support and grief counseling. We also provide lots of grief support groups in the community. So we're providing services and staying in touch with family members and loved ones for long after the patient dies, if in fact the patient does die on our service.
No, I think that's a really good point that you make, especially about the support groups. We know from our community how valuable support groups and counseling in general can be. Susan, I was just curious today if you could talk a little bit about what some of the misconceptions about hospice might be. Have you encountered any misconceptions? Do you feel that there could be a stigma surrounding hospice? And this is an important question for folks that may have heard different things or don't know what to expect.
Sure. Yeah, absolutely. I think there is a stigma to hospice that creates kind of some emotional barriers to people being able to get this wonderful kind of care that's available to everyone. So I think it's about sort of the stigma about death in our society. People are afraid of sort of talking about dying, even though it's something we know everyone's going to eventually experience is death. So, and also I think it's about a sense of control. I think we have a sense that we, or maybe the medical field, has more control than we actually do. So there's this idea that, like, once you go on hospice care, or when you go on hospice care, that's it. You've given up control and decided that death is going to occur. Hospice doesn't have that power, right? We still don't know what's going to happen to someone just because they go on hospice care. We know that they now may have, they have a diagnosis of something that may be terminal for them, but we're going to provide this awesome, awesome care, this comprehensive and holistic care to patients and families, and we don't have control of what's going to happen. Sometimes people come on hospice care and then eventually are discharged from hospice care because they're no longer in a terminal situation. Sometimes people come on hospice care, they go off, then later on they come back on. Sometimes people come onto hospice care and then sometimes it is their end of life and they stay on hospice care until they die. So, but we don't have control of whether that's going to happen or when that's going to happen. We're just there to provide care for people who are in a situation of having received a diagnosis of an illness that could be terminal. Yeah.
Thank you. I really like the person-centered focus of the multidisciplinary approach that you talk about and how important that is.
Yeah.
We had the pleasure of talking before the recording today. Yeah. And I know, you and I have talked about grief, and you mentioned this term, grief warrior.
Yeah.
And it really resonated with me. And I was hoping that maybe you could talk a little bit more about that term and what that phrase means to you. I would love to hear it because I think it's such a beautiful message.
Yeah. I've been using that term for years, and it's usually when I'm speaking to, people about our grief services and about grief in general, just learning about grief. And, I after we talked, I Googled it and it's out there. I other people use it too, but, I think, many great minds think alike. But, what I mean when I say grief warrior is that, people who have known loss, right, and who are grieving often become isolated because the same stigma we talked about, people don't kind of feel comfortable hearing and thinking and talking about death. And so, people who are grieving can become isolated. And I always try to empower these people, people who are grieving and people who are willing to talk to people about their grief, that we are grief warriors, right? That we are here to say that we're not afraid to be with and care for and talk to people about their losses in an honest and supportive way. Yeah.
So powerful, those words. I mean, we've all experienced as humans, as you know, some form of grief in our lifetime. Right. And that's different for different people as part of the human experience. So, I mean, those words really resonated with me when you talked about, grief warriors. Susan, that's such a powerful message that you shared when we think of grief warriors, and that all of us have experienced grief in our lifetime. So thank you for that message. It really resonated with me. And you mentioned something earlier regarding your role in leading the chaplaincy at Merrimack Valley Hospice. And what I was curious about is if someone is not affiliated with a particular religion or doesn't find themselves to be spiritual necessarily, can they still partake in those services? And what would that look like? What does it look like when a chaplain is involved in your life as part of hospice?
Right. Absolutely. I'm so glad you asked about that. I think it's really important. And that's why, my title is, bereavement and spiritual care, and why chaplains are, within the counseling services sort of department, right? We consider chaplains to be providing spiritual counseling. So counseling being the operative word there, right? So, a chaplain is, by definition, that word is somebody who is with people when they're experiencing something very, very difficult. We think of chaplains in the military, we think of chaplains on police forces and fire departments, same kind of thing. A chaplain is someone who is willing to go through it with whoever is experiencing difficult times. Our chaplains as spiritual counselors, right? And like you said, even if someone doesn't consider themselves to be spiritual, but especially, it doesn't have to do with religion, right? It used to be that chaplains were called, interdenominational. Then that was sort of corrected to interfaith. Now I've corrected, we're at our hospice, we've really made a huge correction on that. It doesn't have to be, you do not have to have a religion. Chaplains aren't there representing any specific religion, and they're not there representing religion at all. You do not have to have any kind of specific religion. And again, you don't have to consider yourself spiritual. Chaplains are going to talk to you and give you counseling about meaning, right? How you're making meaning of the experience that you're going through, how you've made meaning of your life in the past. And that's something that I think is universal, right? A chaplain can provide this counseling for anyone. And that's how they're trained, right? Is to understand the humanity of each of us as we experience something new, something difficult, and what that means for us.
I think that was beautifully said.
Yeah.
And, there are many people that have various beliefs and those that don't. And I think it's very inclusive that the chaplain, can work with you and walk alongside you, supporting you during this experience if you choose. So I think that's wonderful.
Exactly.
So today, Susan, we really want to thank you for your time and your expertise today. But I was just curious, if you had one takeaway message for our community, what would it be regarding hospice care?
Yeah. I think the biggest takeaway is just, what I really want people to know about hospice is that, hospice is about living, right? Hospice is for the living, and it's about living, right? It's about helping people live life on their own terms, at any time, but even and especially at end of life. That's when it's most important, I think, to be able to make your own decisions and to be able to live your life in a way where you are comfortable, you're not dealing with pain, and you're able to pursue and do all of the things that give your life meaning. That's what hospice is about. It's about living. It's not about death. It's about helping people live their best lives. Yeah.
Thank you so much. And I remember before the recording, we're actually talking about when someone is on hospice, it could even look as if, they are not, it's not just being comfortable. You could also be comfortable and be very active.
Yes, absolutely. Absolutely. Because what we know is finding that balance between comfort and being pain-free and retaining your lucidity, which is that needle that our medical staff is so devoted to finding for each person, that when you get that balance, right, then that is when you are able to pursue and be active and do the things you love and be with the people that you love more fully. And that's what makes hospice care so, humanistic and person-centered, as I think we've kind of touched on. Yeah. It's about the person, right? It's not about their illness. It's about the person. Yeah.
Well, Susan, I want to thank you for such a wonderful interview today,
Yeah.
discussing hospice care and counseling and the chaplaincy and everything that supports caregivers, family members. I think it's really going to be important for our community. And your message of hospices for the living is tremendously supportive. And we want to thank you for the work that you do.
Oh, you're welcome. Those are kind words. I appreciate being here and getting to talk about it. Thank you. Yeah.
That was such an incredibly powerful session. In my role as Director of Caregiver Support Services, I've worked with a lot of families through every stage, including the terminal stage of care. And I know that sometimes people are worried when we bring up the opportunity for hospice. I hope that this session today resonates with you, as hospice is an opportunity for additional services and supports. It's an opportunity to feel empowered about your and your loved one's care plan. And it's an opportunity to think about your goals of care, your values, and the great loves in your life. We heard words like person-centered, grief, love, being active. Those are things that maybe people didn't think about hospice before. So if you think that hospice is something that could benefit you or your loved one, talk with your loved one's primary care physician or their treating neurologist and find out, do you think that this is the right fit for us at this time? It can be something that can be part of your care plan to be used today or in the future. We hope that this session has been informative and will help to increase your knowledge about services and supports available for individuals living with a diagnosis of dementia, their care partners, family, and friends. The MGH Frontal Temporal Disorders Unit is a clinical research program dedicated to providing the highest quality of care while working tirelessly towards a cure for frontal temporal dementia, Alzheimer's disease, and related disorders. We thank you for listening to this session of our Community Forum Friday webinar series. All of our educational programming is recorded and available on our MGH FTD Unit YouTube channel. We hope that you stay safe and well, and we look forward to seeing you again next time.